Yes, I'll first like to thank the organizers of the this conference for this invitation to present on cardiac surgery in West Africa. My name is Mark Tettey. I practice in Kolebo Teaching Hospital, and this is one of the largest hospitals in the West African sub-region, with a bed capacity more than 2,000. My outline for the presentation will follow this. I'll give you a brief introduction and a historical perspective, and present and the present cardiac programs that we have, and the place of foreign missions. I would like to talk briefly about that, and also strategies for strengthening cardiac program in the sub-region, and I'll draw my conclusions. Now, the West African sub-region is made up of 16 countries, and with a population of almost 418 million people. Looking at the population of Nigeria, that's about 200 million, almost from half of the population of the sub-region. But then we are the one of the poorest regions in the world. And this is a limitation to cardiac surgery program. Poverty is a limitation to cardiac surgery programs. And we all know that cardiac surgery all over the world thrives on three main pillars. We're talking about infrastructure and equipment, human resource, and funding. And the foundation of these pillars is the GDP. The GDP per capita income in the West African sub-region is extremely low, less than 2,000 United States dollars. For Ghana, it's just a little bit above that. But Nigeria, for example, last year was less than 1,000. And when you compare this to developed countries like the USA, it's more than 80,000 USD, and in Europe was more than 50,000. So the gap is so wide, and this has actually accounted for the struggling of cardiac surgery programs in the West African sub-region. But then we have a history. 4 countries out of the 16 had a history of open heart surgery. These countries are Ghana, Nigeria, Cote d'Ivoire, and Senegal. And I would like to talk briefly about this history. Professor Charles Ismon, supposed to be the father of heart surgery in the West African sub-region, did his first closed commissurotomy in 1960. And this was followed by 2 open heart surgeries under hypothermia and surface cooling in 1964. But he faced stiff opposition from his colleagues. And why? Because when these 2 surgeries were done, the hospital appears to come to a standstill. He has to marshal the workforce and so many other things that seemed to disturb the normal program of the hospital. So that his colleagues became so opposed to what he started, and that actually truncated the program until 1989, when Professor Frimpong Boateng appeared on the scene. He was trained in Hanover, and he was the first Black, to have transplanted or carried out heart transplantation in human beings. So he started in 1989 and did his first open heart surgery. That was the mitral valve replacement in 1992. And the center he established survived till now. And the National Cardiothoracic Center in Ghana is the only training center accredited by the West African College of Surgeons in the West Africa sub-region. Now, Nigeria also have a similar history. Prof. John Weaver, University Teaching Hospital, Ibadan, performed also the first closed commissurotomy in 1960. And the first open heart surgery was by Professor Fabian Odeku, assisted by Professor Magdi Yakub in the University of Nigeria Teaching Hospital, that's Enugu, in 1974. And Nigeria continued briefly with open heart surgery, but unfortunately, economic difficulty, political instability, corruption, and so many other things actually crowded the progress of the open heart surgery. And so that actually fizzled out, and they now depend heavily on missions from Europe and North America. Cote d'Ivoire, they were the first to have a cardiac institute in the sub-region, and these were established by French surgeons and local surgeons. That's Professor Koulibaly and Ouattara in 1978. and they did quite a lot. And it subsequently became the referral center for the West African sub-region. And this program was continued by Professor Yagni Angate and his team, and continued until recently. So this center appears to be hibernating now because of economic difficulty and civil strife. There's nothing really going on now in that country um, in respect of open heart surgeries. Now they're coming in Senegal. They taking a cue from Ghana and Cote d'Ivoire. They performed their first heart surgery in 1995. This was by Prof. Ndiaye and his team in collaboration with an American surgeon. So the Department of Thoracic and Cardiovascular Surgery in a FAN University Teaching Hospital, Dakar, now has an established program from 1995, and it is still an active program. They are doing quite a lot now, and it's the referral center for most Francophone countries in the West African sub-region. Now, let's look at the present cardiac programs we have it. For now, the active programs in the sub-region are in Ghana, Nigeria, and Senegal. Briefly looking at Ghana, the burden of congenital heart disease alone is 8,000 per year. But we have only 10 cardiac surgeons, and out of these 10, only 6 can do open heart surgery. We have 2 centers now. The first center, that's the National Cardiothoracic Center, and then the cardiothoracic unit of the University of Ghana Medical Center. That came to the yeah, that came maybe about 3 years ago, and supporting heart surgery now. For the main center, we do about 2 to 4 open heart surgeries per week. That's about roughly about 150 per year, and mainly children, 80%. And the second heart center, they do about 50 heart surgeries per year, the cardiothoracic units, and mainly they operate on adult patients. Looking at the numbers and what we have on the ground, you realize that we have a lot more to cover when it comes to open heart surgeries. Nigeria have 3 centers, 2 public hospitals and 1 private, but all put together, they do about 2 to 4 open heart surgeries in a month in these 3 centers. And that is woefully inadequate, because when you look at the population, you have 200 million. So this is just scratching the surface of the cases they are supposed to be doing. Senegal is doing quite well. They do more than 50 cases, 150 cases per year, and these are mainly pediatric. So when you look at the sub-region, this is what is happening. This is a number of cases that is done with a number of patients that is supposed to be um, in the sub-region. Let's look at foreign cardiac missions and their place in helping to solve the problem of open heart surgeries. They become necessary because of the limited workforce. We don't have enough cardiac surgeons, cardiac anesthetists, cardiologists, perfusionists, ICU staff, and all that. And we don't have funding enough to support open heart surgery. And when it comes to infrastructure and equipment gap, it is a serious one. So cardiac machines tend to fill this gap in a way, but then they have limitations. We benefit from them, all right, but the limitations are there, which we need to look at. Benefits this for the patient, they support patients when they come, they operate, but how many? The numbers are very few. When we have a mission will not operate up to 20, maybe 10, and they then tend to select patients they operate on just because they want good outcomes. So the complicated cases are left behind. And also because they operate and leave, follow-up becomes a problem. And so follow-up is not as it should be. So these are some of the limitations when it comes to patient support. Healthcare providers, because of the low case load and per visit, it has no impact really on training, and skills transfer is a challenge. So that is the other side of it. And health institutions may have some support because of the equipment they leave behind and the consumables. But the challenge is most of this equipment left behind um, uh, are not used, and those that are used, maintenance becomes a problem. And the consumables, well, it can support, but some of these consumables too may not be used. So strategies for strengthening cardiac programs. I would like to use the Ghana example, and I would like to touch on infrastructure, funding, human resource, politics and advocacy, and research. When it comes to infrastructure, we have a dedicated center in Ghana, and for cardiac surgery to strive in a sub-region, we must strive to build a dedicated center, and this has helped Ghana, and it's the only accredited center for the West African sub-region for training cardiothoracic surgeons. Our center has 6 ICU beds, AGU beds 6. We have 30 beds for the ward and 10 beds for dialysis. We have 2 dedicated theaters, pharmacy also dedicated to serve the center. We have a lab, a hematology that does hematology and biochemistry for our patients. X-ray unit serves the ward, the OPD, and the ICU. We have a cath lab and also echocardiography suite. Um, hu- hu- Human resource development is key for us. And we want to develop, if we want to sustain this program, this is one of the key things we have to look out for and work on seriously. And for the center in Ghana, we have championed the commencement of the critical care nursing school that helps to feed the ICU nurses. We have perioperative nursing school for the theater nurses. Training of perfectionists had been a challenge recently, but thank God we have a center school in India now that's helping to train our perfectionists. Anesthetists, we depend on the West African College of Surgeons to help us with anesthesia training. They come to join us and have top-up training. uh, uh, we send them out to polish up, and then they come back and support us. Recently, we've sent two to Italy. They are back with us and they are helping. Training of surgeons, we train our surgeons, but not totally. After acquiring the basic knowledge and skill, they are sent out so that they to high volume centers to polish up and acquire more skills. So far we've been able to train 10 surgeons from Ghana. We've trained 20 surgeons for Nigeria and 2 others. We have collaborations, and I would want to talk about targeted missions now, because we have collaborations with the Boston Children Hospital in the USA. We have meetings with them. We discuss cases with them, and with the complex ones, we keep them for when they come, or as we arrange with them, they come and help us with the complex cases. It's because of them that we are now able to operate on children less than 10 kilos, and the skill transfer is so well coordinated because we have surgeons already on the ground. So when they come, teaching becomes easier. And because there's already an ongoing program, skill transfer makes it's possible under that circumstance. So, but then the issue with human resource development has been the low remuneration of staff that we have in a sub-region. Um, it's it's bec- it's becoming a problem, but then we have to devise strategies to be able to solve the problem. Uh, we talk about this staff seeking greener pastures outside, and what happens is once a staff is well trained and you start depending on them, then they present their resignating letters just to seek greener pastures outside. This has been a problem, but then we trying to work around it and make sure we have some stipend to encourage staff to stay on. Funding is a problem, but then how did we get around in Ghana? Ghana Center has an institution, foundation that is, let me say, an institutional foundation that helps to mobilize funds from industries, from philanthropists. And that foundation, we call it the Ghana Heart Foundation, helps. That was what actually helped initially to support patient funding. But now what they are doing is to support buying of broken down equipment and some consumables. They still sponsor some patients though. But now we have private foundations that are supporting a lot in patient sponsorship. We have private foundation that are sponsoring about 50, 60 patients a year, 20 patients a year, 30 patients a year, and all that. And that has been very, very helpful. Industry support is also very important in our case. After they are convinced that we are doing a good job, what do? They vote some monies every year that helps to support patient care. Government also comes in when we approach them, especially when we have equipment breakdown. They come in to support. Insurance reimbursement has been a problem because the national health insurance is not that well endowed to be able to sponsor heart surgery. So it's a private one. So even the private one, the premium that is required, most of our people cannot, except of course when we have companies and industries that do that for their employees. But then these are very few. So we don't get a lot from insurance reimbursements. And out of pocket finances is just about 5%. We also do not depend on this. Funding of open heart surgery, the cost for adults is between 8 to 12,000 US dollars, and these are the cases we do: cabbage, valve replacement, repairs, aortic root replacement, with the heart tumors of the heart, and pericardiectomies. For children, the average cost is about 7,000 USD. Do that: ASDs, VSDs, tetralogy of Fallot, double atrial ventricular and pulmonary stenosis, and a few other cases. For politics and advocacy, you have to influence government, industries, and stakeholders with information. Government should acknowledge cardiac centers as integral part of a well-functioning health system. They should not regard um, heart centers as luxury. When it becomes part of their health system, they are well able to budget for it and fund it. The increasing burden of heart diseases, including the congenital heart disease, and the impact on society has to be drowned so that so that the government, will understand the need of uh, heart centers and supporting heart centers. Cost of surgery, in a few cases sponsored by the government, need to be highlighted so that the government knows that the, the cost of surgery outside for one patient can sponsor about 5 to 10 patients internally. That we sometimes it's important to tell the story of heart surgery program. We often roll out sometimes documentaries of what is happening at the center, and that helps to whip the interest of more people to join in to support heart surgery programs. Research is very important. You tell the story, you can tell your success story with data. And sometimes there are some pathological peculiarities which are very common in an area, in a sub-region. Rheumatic heart disease, endomyocardial fibrosis, and a few other things that are very peculiar in our region. Because we have the numbers, we can do research and then come out with the best protocol for management. And research also improve on the practice of cardiac surgery in West African sub-region. So in conclusion, I would like to say that the West African sub-region is lagging behind regarding the three pillars of cardiac surgery. I mean, you can see from the presentation I've just done, the individual countries' GDP are low to start with. We need to define our problems and design strategies to be able to overcome the challenges that exist with us. And with this, we can introduce innovation to overcome these challenges. If we just leave things to stand, we can never start, and we can never continue. Political will and commitment is very essential. We can't do without the governments of the day. Collaboration among countries in the sub-region is very good. It helps in the training, and then with the centers outside, they can also retrain and transfer skill. That would also support the development of the heart surgery program as we have it here. A locally trained surgeon is key to the survival of cardiac surgery program in the West African sub-region. We should make sure that wherever um, cardiac surgery program has the potential to develop, there's a locally trained surgeon, because that person that holds the future to the cardiac surgery program in any of the countries. I thank you for this opportunity to present on the picture of cardiac surgery in the West African sub-region. Thank you very much. These are my references.